for organizing.
Okay, thanks. I'll mute myself.
So, shall we start?
Well, let's go. There was Dr. De Oliveira is not here yet, at least I think. Your co-operator.
Yes, but I think that we should start in terms of not losing time. Maybe he will join us. Hopefully, he will join us in a due time. And I would now like to officially start this WFNS Rhoton Day devoted to peripheral neurosurgery. In terms of continuation of our education activities related to the neurosurgery in general, and particularly to the peripheral neurosurgery, it is my pleasure to moderate this meeting together with my co-chair, Dr. Alessio De Oliveira from Angola, who will join us soon. And I would like to introduce a distinguished presenter of today, very important topic, Professor Dr. Christian Heinen, head of neurosurgical department in Germany and section chair of European Association of Neurosurgical Society for Peripheral Neurosurgery. Very experienced and very devoted neurosurgeon who is doing neurosurgery in general, but especially peripheral neurosurgery on the expert level. So this presentation today is related to the anatomy and surgical approach of the median nerve. So it is my pleasure to announce Dr. Christian Heinen to give us this presentation about the importance of anatomy and surgical approach to the median nerve. So, Christian, floor is yours.
So, thank you very much for this very kind introduction, dear Lucas. Thank you to all the organizers and especially to Imad for preparing all the advertisement and the invitation to be here. And I also want to thank Mariano from Buenos Aires for including me in these activities. So I will try now to share my screen, and I hope it works. So could you give me, please, a feedback if you can see the screen?
Yes, sir, we can.
Perfect. Okay. So today is dedicated to one of the functionally most important nerves, the median nerve, without whom none of us would be able to do what we're doing, and a lot of other professions would not be able to do what they do. So this is a very important, very interesting nerve. I have nothing to disclose, and I will start, of course, with, as requested, with the anatomy. That will not only include the external, let's say, macroanatomy, but also the internal, the topography of the nerve, because this is important when, especially when going to reconstructions or to nerve transfers. So this is something that I would just touch, but the main topic is about the anatomy of the median nerve. So if we talk about the median nerve, we all know this is one of the most, or maybe the most important nerve providing the hand. And as you can see, from its branching off the brachial plexus, more or less until the elbow region, the median nerve usually is not providing any muscles. There we'll show you that later, interconnections with the musculocutaneous nerve. So sometimes the median nerve also provides elbow flexion, but mostly it starts with the pronator flexor group at the elbow, and then as the next branches, it goes down to the deep flexors of both thumb and index finger via the interosseous anterior nerve, and then finally going down to the hand with the main branch going to the thenar muscles that then provide mainly the the elaborated thumb function. So this is for motor, and as in all the peripheral nerve, and this is one of the beauty about peripheral nerve surgery, you have these cascade or this branching and supply pattern of each nerve that allows you, in a lot of cases, of course not in all, but in a lot of cases, to tell more or less where the lesion of a nerve is, be it a compression, be it a traumatic lesion, be it a tumor, and so on. So this is for the motor function. And of course, by providing mainly the first 3 or 3.5 fingers of the hand, so our main use fingers, the sensory function of the median nerve cannot be overestimated too much. So in terms of treatment of the median nerve, you need always to consider to have back motor and sensory functions, since this is of utmost importance for any being, and especially for the development of the hand, for example, if you have a lesion in a baby. So going more precisely into the sensory function of the nerve, you have basically 2 main components, which are the digital cutaneous branches that you see here in green, and the palmar cutaneous branch that usually branches off a bit proximal to the wrist for the palmar aspect of the hand. And as you can see here, and this is a classic, and I'm sure that most of your patients will fit in this pattern, that the radial part of the 4th finger is supplied by median nerve, whereas the ulnar nerve takes over the rest. And this is in contrast to spinal nerve compression of C6 or C7. This is a very, let's say, safe and easy way to distinguish. So keep in mind the sensory supply of the hand, not only for pure median nerve lesion, but also for differential diagnosis of disc hernia, spine level, TOS, and so on. So just to show you this. And of course, and now I showed you the supply, and the supply means that within the nerve, there needs to be a certain distribution of the nerve fibers that then eventually supply muscles and nerves, muscles and skin. And if you go into details of the median nerve, you will find a distinct distribution of fibers over certain levels, as marked here, starting from the hand, where of course the forearm plexus, pronatus, and so are out. But you see that this is a very specific distribution of nerve fibers. I will not go into the very detail of it, but it's worthwhile that when you deal with median nerve lesions, and especially partial lesions, so patients have left some of the functions, that you keep in mind where to find them. And especially when reconstructing, you need to exactly, for example, in terms of grafting or also in nerve transfers, when you want to address certain functions, you need to be sure where these functions are located within the nerve. So this is taken from a fantastic homepage from the Washington University, from the US. So it's worthwhile to have a look there and to go through what they have to offer. So internal topography is important. Of course, there are variations. This is another paper, and you see that I will not go through this in detail, but you see that the distribution is a bit different. And of course, when dealing with such an important nerve as the median nerve, you will not be surprised that there are a lot of variations that we will encounter later on during this talk. So in terms of formation of the nerve, so this is the median nerve, and you can see here the classic. Well, in German we call it Medianusgabel, which means the fork of the median nerve, which is this. So it's directed upwards. So you have the contribution of the lateral cord with the musculocutaneous and the portion for the median nerve. And you have the contribution of the medial cord, that then one branch is the ulnar nerve and one branch is the median nerve. So this is where the actual median nerve starts. And if we have a look at how many roots or spinal nerves provide this nerve, so this is the median nerve, and you see that there are 1, 2, 3, 4 colors in it. So usually it's from C6 to T1 that the median nerve will have contributions from. And of course, from C6 it will be more the well, one is the sensory, the dermatome, and the second is the forearm flexors. And the more you go caudally, the more it gets into the hands. So T1 usually provides the thenar and lumbrical muscles. So just for your, for your thinking in terms of assessment of a lesion. So even by the pattern of loss of muscles or loss of function of the median nerve, you can again see or conclude where you will have the lesion, if it's way up in the brachial plexus or if it's further down, let's say forearm or the hand. During the in terms of variations, this is work that dealt with variations during the fetal period, and you see here one very axillary type of branching off of the median nerve, and then you have one very far distal at the upper arm level. And here you see all the different possibilities how the medial cord, lateral cord, inferior, the medial cord or the lateral cord can contribute to the median nerve. So all this is something that you need to keep in mind because it's highly individual. And it goes on. This is an example from Iran. And again, they deal with the variations of the median nerve in the arm. And you see how different the branching patterns are. So sometimes maybe you will look for the median nerve, and you will find that this median nerve, as I alluded to before, also supplies the elbow flexion function because it has contributions with or intermingling with the musculocutaneous nerve. In fact, in primates, the median and the musculocutaneous nerve are one structure, at least in some species. So most probably the evolution of the median nerve with the elbow flexion was connected, as this makes sense because if you want to flex the elbow, you can use your hand. So I guess this could be part of it, but I will not get too philosophical about this. So again, this is a study from India, and you have this distribution that more or less is what we saw before. So most of the median nerves start in the axilla, and some start in the upper arm level. So something that needs to be kept in mind as well is that you have anastomosis between median nerve and ulnar nerve. Maybe the most prominent is the Martin-Gruber anastomosis, which is fibers from median nerve to ulnar nerve in the forearm, and of this anastomosis, the anterior interosseous nerve branches off. So it has both supply from ulnar and median nerve. The second one is the Marinacci. It's still at the forearm level, but as you see, the direction of the fibers is the other way around. So this is some contribution of the ulnar nerve to the median nerve, and the interosseous anterior nerve is not part of the anastomosis. Going more downwards to the hand, you have both the Berrettini, which is from ulnar to median nerve, and the Riche-Cagneux from median to ulnar nerve. And of course, in these patients, sometimes you have severe lesions of the median or ulnar nerve respectively, but nonetheless, the clinical impact is not that high because they can compensate with by the co-innervation of these anastomoses. So this is something that you can assess with ultrasound if you have the suspect that something like this is going on. So we will deal with different pathologies, and we will go through the different levels of the arm. You see here stratus arcade, you see a pronator problem, you see a problem with the superficial finger flexors, you see the reversed palmaris longus, and of course carpal tunnels. So we will talk about some of them during this talk. So let's start with the upper arm. So in the upper arm, the anatomy is quite straightforward. You have the bicipital sulcus, which is between the biceps and the triceps, and you palpate the humeral bone, and maybe you even palpate the pulse of the artery, of the brachial artery. So then you know that you will find the median nerve there, because it's of the big nerves. You open up, first thing you find is the fascia. On this fascia, you have a cutaneous nerve. And this is the medial cutaneous antebrachial nerve. And sometimes it can be quite big, so please don't confound it with the real median nerve. So basically, the easiest way to distinguish is to use an intraop electrostimulation. So this is what you see, the fascia, and on it, you see the cutaneous antebrachial nerve. And if you compare the caliber of the median nerve with it, of course, the median nerve is bigger, but it can be confounding. So you need to clarify that you see the vessel and the median nerve is directly adjacent to it. This is again from the Washington colleagues. So the first thing after incision, you will find the fat, you will find the fascia, on it you find the nerve. So you know you're not in the correct plane of surgery. So you need to open up the fascia, and then you will find the median nerve, the brachial artery, and underneath you will find the ulnar nerve, you will find the musculocutaneous nerve as indicated here. So this is something, easy access. The patients just lie in supine position with the arm extended, and you will have an easy access and find all the structures very quickly. So this is important for us nerve surgeons. Of course, if there's a trauma, if there's a tumor or inflammatory changes, I will show you some later on. And in terms of reconstruction, maybe some of you have heard about the so-called Oberlin transfer. So this is in brachial plexus lesions with paralysis of the elbow flexion and an avulsion of maybe C5, C6, or nothing to reconstruct autologously. So what you do is you take out, this is the median nerve, this is the ulnar nerve, and these are the branches to the biceps, and these are the branches to the brachial muscle. So what you do is to take out one fascicle of the median nerve, which is mainly responsible for wrist flexion, same for ulnar nerve, connected with the fibers, with the branches to the respective muscles, and then you have an end-to-end suture and coaptation. So the patients later on, while flexing their wrist, will flex their elbow. This is the strategy behind it. So in terms of reconstructive surgical access, this is an easy but important access because a lot of patients benefit from this kind of procedures. Again, what I want to stress and to show you is that when you open up, like you see it in the books, as I showed you here, you think you open up and the nerve is directly there, but that's not true. You need to deal with the fascia, you need to deal with the cutaneous nerves, and you need to deal with them to not hurt them, because if you hurt them, patients will have a very, very difficult to treat painful neuroma. So it's worthwhile to dissect these nerves out and to not harm them. This is why I'm showing these images over and over again. So once more, the fascia, you have the aponeurosis, you have the biceps muscle with the underlying median nerve, you have the artery, and then step by step you dissect everything out. So what we encountered recently, and this was what I was alluding to, so you see this is after opening the skin, after opening fascia, you see the median nerve very superficially, you see the vein, and you see the artery. And what this patient suffered from was a fascicular torsion, as you see here, of the branches to the anterior interosseous nerve. But it was in the upper arm. So my dear friend and excellent neurosonologist, Hinrich Kehle, he discovered this. So I named it after him. And this is what we do. So we take out the penurium, we take out the perineurium, so to decompress and derotate the nerve. So in the end, this is after decompression, and this is after some minutes. And if you look closely, you will find the vasa nervorum filling again. And you see here is still a lack of blood flow. So this should be enough decompression to have the patient recover. And in this syndrome, you not only have what I just showed you, the AIN, but you also have a torsion of the branch to the pronator teres. So this is what you see here, and this is after decompression and derotation. So this axis for the upper arm is the easiest to assess the median nerve and for anything that you want to do with it. So of course, if you have tumors, it's easy to assess. It's a very straightforward procedure, and you will be very happy and very quickly familiar with dissecting the nerve out in this manner. If we move down to the cubital area, we need to keep in mind more structures. So we have the stratus ligament that is described as often. In my experience, it's very rare. And you have several possibilities of compression in this regard of the median nerve. You have the humeral and the ulnar head of the pronator teres. I will show you later on that there are a lot of variations again, and of course. So this can be a cause of compression. You have the lacertus fibrosus of the biceps that can be very compromising to the median nerve. So another side of compression. And if you move a bit more down, you will find the FDA's arch that can be very sharp and very compressive. So this is something that you need to assess pre-op and intra-op to be sure that you completely decompress the nerve. This is from an old book, very known German anatomist, Lanz and Wachsmuth. So they described already, so this is why everything is in German. I apologize for that, but the message is that you need to be sure and dissect out and find out what the actual course of the nerve is. Is it between the two heads? Is it within one of the head? Or is it just underneath both of the heads? And you see that the main thing is that the nerve runs between the two heads of the pronator teres muscle. So these are the two possible compression sites. So the arch of the pronator teres, or the arch of the FTS, so the superficial flexor digitorum. And so this is the nerve, AIN, anterior interosseous nerve, main nerve. And you see the compression of the very sharp ligament or tendon of the pronator teres. This is just another example for that. So this is more at the lower part, the caudal part of the muscle, and this is more at the entrance in the pronator channel. So all of this, since I'm a big fan of nerve ultrasound, all of this is something that you are that you can assess dynamically with using ultrasound. I will show you one example later on why I love the ultrasound so much. So talking about variations, because in every talk about anatomy, you have always to talk about variations, and you see here the different patterns of the branching of from the main nerve the AIN, very important. I will show you why in a few slides, and the different branches to the pronator and flexor carpi radialis and so on. So this is something that you need to keep in mind, again, not only because of compression and the loss of function, but also if you dive deeper into nerve reconstruction, and you go for nerve transfers. These are all very useful branches that you can specifically direct to one of the functions that you want to reconstruct. So it's very worthwhile to dive into this very interesting anatomic region. So this is a clinical example. So this patient suffered from a lesion of the AIN of the right side. And as you can see, he cannot completely flex the index and the thumb. So this is how the video looks like. This is before operation. He tries to flex, and you see it's minimal and almost nothing, especially for the thumb. You see the index is working, the thumb is not working. And this is how it looks like before. So this is proximal, this is distal, this is the median nerve, and this is a very sharp tendon part of the FDS, here magnified. So what we did was a simple decompression, and this is how it looked like 3 months later. So since he was a smoker, he could light his cigarette again with the right thumb. That before was not possible. And you see how the O gets rounder again. So these are very rare conditions, and the important is to think about them, especially if the symptoms do not match what everybody thinks. If the first 3 fingers are involved in the hand, everybody thinks about or carpal tunnel or the cervical spine problem. But there's more to it, as I just tried to show you. This is why I did not start with a very frequent one, because I wanted to keep your minds open for differential diagnosis. And but of course, we need to deal with the carpal tunnel. I think this is something I will not go through all the epidemiology and so on, but I will focus on the anatomy, because there's a lot of things to add to it. So again, variations. I think there's maybe no, in peripheral nerve surgery, no field that experienced so many damages because of surgeons not being aware of variations. Because if you, the problem is, again, that in these variations, mainly the thenar branch is involved. So one of the main functional branches for hand function. Because with this branch, you guide and you direct and coordinate the thumb. So if you cut or damage it, it's the patient will have huge problems. And as you can see here, so this is the so-called regular one. Then you have a more proximal branching. Then you have a branching coming from the ulnar side. And you have transligamentous, as you can see here, courses of this branch. So if you just cut the ligament without being aware of this, and you are not cautious enough, you will damage the nerve. And so this is something that everybody should be aware of and going through, and keep in mind, especially doing surgery, that this is a very important structure to preserve. And well, of course, you have the books with all these kind of incisions, and in the end, everybody will find a personal solution to do so. So what my main target is to direct the incision so it would be ending between the 3rd and the 4th finger. So you make sure that you are above the median nerve and not too ulnar or too radial, so that in the end the nerve is not compressed. And then The second very important thing is, and in my experience, the main reason for recurrent or persistent carpal tunnel is that the flexor retinaculum is not touched. Because the first thing after inciding and pushing aside the subcutaneous fat is that you will find the aponeurosis of the palmaris longus muscle, and that is not the retinaculum, and you can see it by the direction of the fibers. So this is why I chose this slide. You see the fibers are going like a corona radiata, and the flexor retinaculum is purely transverse. So by the direction of the fibers, you will know if this is aponeurosis or if this is flexor retinaculum. So even if everybody says, yes, carpal tunnel needs to be done in 5 minutes, this is not correct. So you should dissect the nerve as meticulously as you would do it while dissecting the brain, the spine, brachial plexus, or whatever. So you need to take your time. And to keep in mind the different layers that you need to go through to be able to do a proper decompression. So again, you have the fibers of the palmaris longus tendon directed towards the fingers. This is why it's this corona-like. And then you have the transverse course of the fibers of the flexor retinaculum. So this is very important to reassure that you will actually decompress the nerve and not cut whatever. So this is what I was just trying to tell you. So subcutaneous fat, and you see the fibers of the aponeurosis. You just split it apart, and then you have the flexor retinaculum that is then opened and completely dissected. So you make sure that the median nerve is completely decompressed. And again, it's, in my opinion, it's not about if you're able to do it in 5 or 5.15 minutes, but it's important that the nerve is preserved and that the retinaculum is completely cut and that the vessels and everything else around is not damaged. So if that takes 7 minutes, then go for the 7 minutes instead of doing, we have a habit to think that fast surgery is good surgery, but this is completely rubbish in my opinion. And the better you know your layers, the faster you will get. And not because you move fast, but because you do every single move with a sense. So this is what makes you fast in the end. And this is also for carpal tunnel, of course. And it's a very good exercise to start with. So what I want to show you is when carpal tunnel goes wrong, because it was done very fast. And what we see here is an ultrasound transverse view, and this is the median nerve. You can see here parts of the nerves are still as they should be, but there are parts of the nerves that are definitely exactly not as they should be. This is a longitudinal view. So first, this is the nerve. You see that there's a lot of compression left because the retinaculum flexor was not cut. So there's compression and there's nerve damage, as you can see. Again, same nerve, scarring, compression, and as you see here in the transverse view, that some fascicles go through, but this is damaged. So there's a continuity, a lesion in continuity, a partial lesion of the nerve. And this is how it looks like. So we have a lot of scar. As you can see, this is the nerve. It's compressed. We need to dissect it out. And finally, need to graft, especially the tena branches, exactly what I was talking before, because they were cut, as you can see. So that was a very quick ride through the median nerve and why it's so important and why it's so important to deal with the anatomy to be sure that you find the right structure and treat it in the proper way. So thank you very much.
Thanks, Christian, for this outstanding presentation, comprehensive presentation regarding anatomy and surgical importance of the median nerve, especially particularly focused on something which might look very simple and which majority of neurosurgeons have in this residency program as some kind of basic education, which is surgery of the carpal tunnel syndrome. So just to tell everybody that surgery of the carpal tunnel syndrome is very famous in the United States. Second name of this surgery is $1 million surgery. So if somebody are not aware of these variations and everything what you mentioned in terms of using any kind of surgical technique for the compression of the median nerve in cubital in the carpal tunnel and injured the recurrent branch or something like that, this then goes into the next stage, which is so-called $1 million surgery in terms of medical, legal, and formal aspects of everything. Not to mention other aspects of surgical importance of the median nerve in all levels, starting from its beginning from brachial plexus to through the all parts of its continuity in upper arm, in the forearm, and this is something that you presented very thoroughly, and I thank you on this. So I don't know if my co-moderator, Dr. Anderson de Oliveira, is present here, but we should now have some kind of discussion. And since I'm not aware about the possibility to use the microphone, there are several questions on the chat about usage of the microphone. Host, I don't know, maybe allow to the participants to use the microphone or send this, or the participants should send a question to the chat and we can model what are the interests of the audience to be discussed. Anyway, Christian, we know each other very well, and the level of expertise, Fiore's expertise is also very well known. So I thank you once again for this comprehensive presentation. And this is an excellent initiative on behalf of all enthusiastic neurosurgeons who are doing peripheral neurosurgery on the expert level in terms of transmitting their knowledge and experience to the wider audience, and in terms of readiness for implementation, everything what is needed to establish and improve the neurosurgical service, which is related to the peripheral neurosurgery everywhere in the world, especially in the low and middle income countries. So, yes.
Hello, this is Mariano.
Yeah. Mariano, yes, Mariano, we are waiting for you. Yes.
Yeah. No, I was reading here at the chat. Someone is asking, Dr. Gugner, should we use a microscope for carpal tunnel release? This is a question for Christian.
Well,
yes,
I don't think that the microscope is absolutely necessary to do so. But of course, I mean, we are all educated to use the microscope. So if you have the possibility to do so, you can. So you have a better visualization. But I don't think that this is required. In my outpatient practice, I don't use microscope or loops. I just go macroscopically. But I know that a lot of hand and plastic surgeons, they always use, no matter what, they always use the loops. And I think this is something that we can learn from. So if you have the chance to use magnification, I think it will be helpful.
And let's move forward with that question. Do you use endoscope, or are you against or for using endoscope?
I abandoned it. So for several reasons. So the first reason is that it never really made sense to me that to put the bougie into the already narrowed channel with the probable hurt that you can cause. But if you look into literature, there is no proof that in that regard, endoscopy creates more damages than open surgery. Maybe, well, in some regions, yes, in most of the regions, not. Let's put it that way. And the second is very easy. In Germany, the endoscopes, especially the single-use ones, are not reimbursed. So I get the same money for open surgery than for endoscopic. So the choice was not too difficult. And the third, if I needed to go back to endoscopy, I would choose the technique that our friend and expert, absolute expert, Kati Krishna from Frankfurt developed. So he basically puts the endoscope above the flexor retinaculum. So he does basically, he has a bird eye onto, it's not in the carpal tunnel, it's on top of the ligament, and he cuts it. So it's like a bird view without putting more instruments into the carpal tunnel than necessary. So if I go back, I would choose that, but I'm quite happy with the open one.
So there is another question. Yeah, there is another question: is in clinically doubtful cases, does normal EPS, which I suppose is electrophysiological studies, rule out carpal tunnel syndrome? And what is your post-operative care protocol?
Well, these are very good questions because the electrophysiology is depending highly on who did it. So if I know this colleague that sent over the patient and he did a thorough or she did a thorough examination, I know, okay, if this person tells me this is carpal tunnel, I will trust, because this person will also tell me I'm not sure. And I would go for further investigation like imaging. And if you trust your neurologist and you know that this person does the exam properly, so compares to the other side or compares to the ulnar nerve, or maybe compares to a more proximal part of the nerve just to rule out that the lesion is more proximal, then I would say if a good electrophysiologist can do most of the work for sure. So as I already said during the presentation, I love ultrasound, and there's no better nerve to be examined with ultrasound than the median nerve. So every patient that comes to my my practice will have an ultrasound, and especially in the cases that I'm not sure. We have seen after pandemia a rising numbers of post-inflammatory changes in nerves that can mimic sometimes carpal tunnel symptoms. So what we started is to, in these, let's say, rare cases or strange cases, to have an ultrasound as well. Plus, I'm very happy that in the very complicated cases, I can refer them to one of the expert MR radiologists in peripheral nerves, Daniela Binari. So I think I have a very nice setup in diagnostic terms. So I think it's not either or, but it's to include everything and to have it tailor-made for each patient. So, and with that, you can rule out most of the pathologies, but it all starts with the clinical exam. So if that goes wrong, everything else will go wrong too. And the post-op care is very simple. I don't use splints. I do not immobilize the hand. I ask the patient to start moving the fingers to play the piano right away from the last stitch on. They have like compression for 3 days. I don't use drains. And I tell them that they need to stop working for at least 3 to 4 weeks, depending on what job they do. So the dirtier their job is, the more they need to wait not to have wound problems. But I do not believe in immobilization after carpal tunnel or using splints or whatever. I don't do that at all.
Christian, I have a question. There is another question, but first I will now give you a question from the chat box. In recurrent carpal tunnel syndrome, the normal anatomy will change. What is your advice? This is a question from Dr. Cubital from Afghanistan Neurosurgical Society.
Well, this is a very important question because all of us are dealing with this recurrent or persistent or whatever kind of problems after carpal tunnel surgery, and it's not infrequent. We see them quite often. So the first thing is, in that cases, I always do ultrasound before, always, and I always want to have electrophysiology as a workup and as a baseline. So I want to know even afterwards in the control if anything changes or not. With the ultrasound, I'm able to see what will expect me, if it's just a persistent or not completely cut ligament, or is there anything else? Is the tena branch destroyed, or is there an epineural scarring or interfascicular scarring or whatever? So this is something we can assess before. And the second, and I think in surgical terms, in that cases, I always use microscope or loops, whoever, but I want to have magnification. And I don't believe in small incisions in revision surgery. So I want to see the nerve in healthy surrounding. So then I know where exactly the branches go to, where they come from, what is scarred, what is not scarred, and so on. So I mean, you don't need to cut the whole arm, but I think you should cut in a way that you see a healthy part of the nerve. You can even do this from distally if you know where the ligament is persistent. So you don't need to cross over the wrist with the incision. But this is something to make the surgery safer and to really know what you're doing, and therefore I want to see the nerve as it is and not where it's damaged, because there it's difficult to discern it.
Christian, I have a question. I'm sure that all of us who are doing this kind of surgery have some experience, which I would like now to share with the audience. So you perform surgery of the carpal tunnel personally, and you perform this without any problems, without any complications during the surgery, no matter which one, neurological or vascular or whatever. So everything went fine, everything went well, and post-operative course is uneventful. At the moment you discharge the patient, and the patient is coming to you for some kind of follow-up in 2 weeks or 1 month or 3 months after surgery. Mm-hmm. And there are some complaints from the patient that they have some kind of sensations which are pain, which is not very difficult, or there are some paresthesias in the first 3 fingers, and these symptoms are lasting, for example, 6 months more or less after surgery, and then slowly but surely diminish. I fully agree, and I fully agree with your strategy for post-operative care, and we are doing the same. I'm doing the same, and everything is practically the same with all these aspects. But there are not a big group of the patients, but several of them have this kind of discomfort after surgery. And my question is to you is, what do you think? Why is that happening?
Well, I completely agree. We have these patients, and at least in our experience, it mainly depends on how long the symptoms were there before. So if the patient had severe symptoms, severe hyposthesia, tenar loss, and so on, these will be the patients that will suffer a long time. They say it ameliorated, it got better, but it did not disappear. What we see, I would estimate in 15 to 20% of the patients that in the first when they start to move the hand properly again, they have pain in the pillar, in the tenar. So when they ride the bike, or when they go into the garden and do some digging, or when they need to push themselves up or something, this is something that I see quite frequently. And I think, well, at least I could not find any explanation for this symptom. What could be the anatomical basis? So I'm not sure, but this usually, and the patients are quite bothered with it, and this usually takes 3 to 6 months to disappear. But if you ask them, even after years, they will say, well, sometimes I have some, some problems when doing certain movements. I don't know if you have the same experience.
Same, the very same. I just want to share this with the audience in terms of if they face this kind of situation, that they have, if they are fully aware and sure that the surgery was completely uneventful and everything was done without any complications and problems, this kind of follow-up symptoms will resolve in this period. In my experience, also, I agree with you that this is a period more or less same like a period they have symptoms before the surgery.
Yes.
Mariano.
Oh, Lucas, there is another question. If you agree, we can read it. What about median nerve dislocation behind the medial epicondyle in elbow dislocation? This is a question from Dr. Ibrahim Shambul.
Well, this must be quite some trauma. This is something I've seen very rarely, and well, this is something that we would try to do in our institution to have it right away as an interdisciplinary approach. So, I mean, if the nerve with this kind of trauma, it will be stretched, it will be compressed maybe by some bony fragments. So this is something, if you just, in our experience, if you just leave it to the orthopedics and traumatologists, and it's not meant in a disrespectful manner, but they know how to fix these kind of very complicated fractures, and I really respect this. But I think if you have the possibility to assess and approach this patient right away in an interdisciplinary manner, so you can check the nerve right away and you know if this is something that has a chance to recover or not, I think this would be the best way to go. If you have the possibility in your institutions, this is what I would recommend, and this is how we would do it.
Perfect.
And this is all about carpal tunnel syndrome and in terms of entrapment syndrome, so the median nerve, which there are some other entities also, but shall we say some words about reconstruction or nerve repair of the median nerve in terms of traumatic median nerve lesions?
Well, I think it's always worthwhile to try to in no matter the timing, we have the big discussion of timing in the repair of traumatic nerve lesions, and we mainly speak about motor function. But as I mentioned before, the median nerve has an immense and paramount sensory function. So in this specific nerve, I would also address very late lesions, just to give back some sensation to the hand. Of course, it will not be perfect, but just to let the patients know if he cuts himself or burns himself and so on. So I think it's very worthwhile to use all strategies possible. This includes grafting, this includes nerve transfers, everything that we have to restore not only motor function, which of course is crucial, but also sensory function. So with the median nerve, I'm very generous with the indication for surgery and do not stick to, let's say, the time frame of 3 to 6, 9, whatever month. But if we can, even after, and the younger the patient, the more I would go into. So the younger the patient, the more, I don't like the term aggressive because we don't do harm to them, but I would say I would be more prone to operate on these patients, to not only for motor function, but of course also for sensory function.
Yes, I agree completely. Mariano.
There's another question here that I can see. Dr. Tondok is asking, Chris, do you consider using local steroid injections to improve carpal tunnel syndrome symptoms?
No, not really. Well, I think the only group of patients that I saw benefiting on the long run from were pregnant. So in pregnancy and related CTS, this is my only positive experience on the long run, that these ladies did not need to have surgery on the long run. And for the others, you may consider it to, I don't do it personally, so this is something the neurologists do. I only saw that maybe surgery could be, delayed a bit, but not, they were not symptom-free or not cured with this. So, please.
Oh, no. In the case that you receive a pregnant patient that needs, after your consideration, steroid injection. So how do you do it? Do you use ultrasound? Do you do it with anatomical parameters? How do you do the injection in those cases?
Ultrasound for sure. 100%. Not without. I wouldn't do this without. And our main neurologist, Michael Hotz, he's also ultrasound guy, so I know he does it with ultrasound. And he would, after he turned into ultrasound, he would never do it again without. And ultrasound is not some fancy stuff. It's not, a $5 million machine. Is what most of you and most of your anesthesiologists have in their OR everywhere. And the only thing that you need is, if it's 10 megahertz and more linear probe, it's perfect. You don't need, bling bling. You don't need the Ferrari of the ultrasound machines. You can do it with very very good machines, but you will see the nerve perfectly. So it's not about fancy stuff. It's very easy to do, and there's no better nerve to assess in ultrasound than the median nerve at the carpal tunnel or at the wrist. It's so easy to find. If you put the probe and you've never done it before, and you put the probe, you will know this is the nerve. I'm sure.
Thank you. We have another question, which is quite good because we see a lot of interest and a lot of participation in your talk. The question is by Dr. Gumchar. How frequently do you find variations of median nerve as shown by you during surgery, during exact surgery of carpal tunnel syndrome?
Well, rarely, definitely. Maybe in, I would estimate 2 to 5%. So, and I think the main variant that I would find would be the transligamental course or the course of the thenar branch over the ligament, because I don't know how you do it, but I try to not touch the median nerve at all. So I cut the ligament and I leave the nerve alone. I don't inspect it. I don't do anything with it unless there's something very obvious that I want to go for, or if there's something that I saw in ultrasound that it got my attention. So I would say 2 to 5% have these thenar branch variations, and not all of them are dangerous, but sometimes you will find the nerve within the ligament, and then it's so easy to cut. So this is something to keep in mind. So it's not that you will find it every time and you need to know all the variations. It's just that you keep your mind bright and awake, that even in carpal tunnel surgery, you can have these problems. And it's not, I don't like the discussion about 5 minutes or 4 minutes. This is rubbish to my conception, because this makes you think only in time and not in anatomy. And that's, I think, the main mistake.
Thank you. There is another question. I don't know, Lucas, if you want to go on, or may I pose this question?
No, you, Mariano, please continue. Yeah. Since,
okay, this is Carlos Rodriguez question, our friend and colleague from Mexico. He's asking, remarking the importance of fascicular topography in the case of proximal injuries here at the arm, which you shown the anatomy is very clear and very straightforward. What do you prefer? Carlos asked. nerve reconstruction with neurography or graft, or distal nerve transfers?
Well, since this is Carlos, he of course puts these difficult questions. So I could not say, you know, I always, in general, I always do this or I always do that. We started with grafting, definitely. Because even if you look into literature, the grafting results, even for high median nerve lesions, are not bad. They are not perfect, but they're not bad. So I think it depends on the age of the patient. So the younger, the more autologous I would go. So if this is, for example, a kid after a supracondylar fracture with a lesion of the median nerve, I would definitely go for grafting, and I would not do, at least not in first line nerve transfer. The second is, what exactly is the lesion like? Is it a cut? Let's say with a damage, a blunt cut or a sharp cut, then I think, and you have the patient right away, I would go first line for autologous. If you have a long distance and a stretch lesion of the nerve, where the nerve has a damage about 10, 15 or whatever centimeters, and you need to use long grafts, and you don't know if you really end up in the not scarred part of the nerve, then, and this is, of course, I come back to ultrasound, you would see this, of course, or Dani would see it in MR, but then I would go for nerve transfers, because I know that these long grafts that are reaching high up to the axilla or even more region, that you will have worse results. So especially in the stretch lesions. And something that some of our colleagues, for example, Robert Schmidhammer from Vienna, propagate is that they do a combination. So they do grafting plus they call it babysitter nerve grafts, for example, to maintain the muscles of the tenar or that they will restore sensory sensation in the hand with using a cutaneous branch and so on. So I refuse to decide which one I use, but I would always do it according to the very individual situation of the specific patient. I hope this is sufficient for Carlos, but I'm not sure. He will tell me.
Christian, thank you very much for this explanation. Any kind of questions? Can I see just a second? This is Carlos Rodriguez, what we in it, and I don't see any more questions in this chat.
No.
Is there any question more now to be sent in 1-2 minutes, because we are about to close this webinar, which I believe that all participants consider useful for them in terms of facing the relevant information about what is the importance of the anatomy and surgical approach to the median nerve. If there is no, there are many comments in the chat. So this is something which we go through all, and all comments are very positive, with the congratulations to the presenter and to the organizers of this webinar. So this is once again very important to have this kind of education aspects in within the neurosurgery, since peripheral neurosurgery is an essential part of neurosurgery. And I would like to now to thank all participants for their presence and their active participation in this webinar. Also, I would like to thank Mariano, who raised this initiative, or I would say coordinate this initiative together with organizers, which are WFNS Educational Committee and Rhoton Society. So finally, I would like to thank Christian for his efforts to make this presentation very comprehensive in all aspects and to touch all important aspects, not only regarding anatomy, but also for interneural topography, systematization, and of course, importance for the surgical aspects in treatment of these patients. There will be a series of these webinars related to the peripheral neurosurgery until the end of this year. So I cordially invite all participants to follow these channels for communication and information about the next webinars, and you are more than welcome to join us in our future endeavors. So that's it for now. And if Cristiano Mariano would like to have any comment.
Well,
No, thanks, Lucas, for moderating, and thanks, Chris, for this wonderful talk.
Thank you very much. I just want to have one advertisement from the EANS. We will have the annual meeting in Bulgaria, in Sofia, from October 13 to 17. And on Sunday, October 13, there will be a pre-congress course, whole day devoted to peripheral nerve, with a lot of speakers that you will see during this fantastic series of anatomical presentations. So feel free to contact me or the EANS and be part of it. So thank you very much to all organizers. Thank you, Mariano and Lucas, and see you very soon.
Thank you.
See you very soon. Yeah, I officially close the webinar, and we can now leave this webinar, and the organizer will shut down it or close it. Thank you very much. Have a nice weekend.
Okay. Have a nice weekend.